I shall begin my talk with a brief overview of the strength and limitation of the bone scan, and then further proceed to highlight the incremental value that SPECT adds to bone scan. So we are all very familiar with the bone scan. It is done after injection of technetium MDP or other bone-seeking tracers. It is sensitive and is able to detect bone abnormalities early because functional changes may manifest before morphological changes. And of course, it's readily available and is affordable. And the bone scan allows a quick overview of the entire skeleton and provides valuable information as to whether the lesion is solitary or multiple, as well as the pattern of distribution, which are important for the characterization of bone lesions. As you can see here, multiple bone lesions, random distribution, that is characteristic of bone metastases, whereas linearly aligned lesions on the ribs, characteristic of rib fractures. The bone scan is able to assess vascularity as well, which is useful. As we can see in this case, this is a young patient with knee pain, no history of trauma. So CT X-rays were normal. So CT scan shows a sclerotic focus in the proximal tibia as the posterior aspect. So is this an osteosteoma? The CT features are not the common typical features of osteosteoma. There is no periosteal reaction, and there is no, and it's found in the medulla instead of the cortex. So is this an atypical osteosteoma? So a bone scan was performed. Blood flow shows increased uptick in the right knee. There's also increased blood flow activity and also intense osteoblastic activity corresponding to the exact location of the lesion on CT. So a hypervascular lesion, no history of trauma in a young patient, most likely it is an osteosteoma, and this was further confirmed on the histology after surgery. So this is an illustration of the usefulness of assessing vascularity for the assessment of post-treatment response in osteosarcoma. So this patient has got a left knee pain, young patient, and there is osteosarcoma in the left proximal tibia, increased vascularity as well as intense osteoblastic activity. After completion of neoadjuvant chemotherapy, there is a significant reduction in the vascularity as well as a reduction of the osteoblastic activity. So this is indicative of a good treatment response to chemotherapy. And there's good correlation between the three-phase bone scan and histopathology for the assessment of treatment response in osteosarcoma. Accuracy is about 88% for a three-phase bone scan and lower 74% if you do just a delayed bone scan. And of course, bone scan is good for assessment of reflex sympathetic dystrophy, as illustrated in this case, three-phase positive RSD. Limitations include specificity, like we all know, and it's because bone scan demonstrates osteoblastic activity, which is a reflection of bone turnover, and that can be due to many causes. There's limitation in characterization and localization of bone lesions. For localization, is especially true in areas where the structures are in close proximity. And of course, the bone scan is inadequate for the assessment of soft tissues. And for knee pain, the soft tissue abnormalities represent the majority of the lesions involved, like for example the meniscus, the ligaments, so on. So with the strength and limitation of bone scan in mind, what does SPECT add to bone scan? Is it worthwhile to perform a SPECT CT? SPECT allows cross-sectional imaging, multi-planar reconstruction, has better contrast resolution, and is able to assess soft tissues better. And the hybrid SPECT CT combines functional and anatomical imaging and allows accurate co-registration of sequential SPECT and CT. And also SPECT and CT are complementary with incremental value. And of course, this results in better detection, localization, and characterization of bone lesions. And also, SPECT CT is able to assess soft tissues better than bone scan because of accurate localization to the soft tissues. And of course, with the companion CT, anomalies can be characterized. And this results in better sensitivity, specificity, and of course, increased diagnostic confidence. Limitations include higher radiation burden, cost, longer examination time, and of course, it is less readily available as compared to the bone scan. So how much incremental value does SPECT-CT add to bone scan? Is it just a little bit? Is it a lot? Is it significant enough to justify the longer scan time and the higher radiation burden? A team from the guys at St. Thomas's Hospital assessed the incremental value of SPECT-CT in the assessment of knee pain. Two-phase bone scan was compared with SPECT and SPECT-CT for 39 patients, 65 symptomatic knees, and 105 lesions. And comparison was made with respect to detection, localization, and characterization of bone lesions. Lesion-based analysis, patient-based, and knee-based analysis were performed. And a wide spectrum of knee lesions were assessed in this study, most common of which is osteoarthritis, and also there is bone tumors, infection, trauma, and soft tissue abnormalities. This graph summarizes the comparison between bone scan, SPECT, and SPECT-CT for localization and characterization of bone lesions in the knee. So, bone scan is accurate for 41%, for localization of 41% of the lesions in the knee. For SPECT, there's an improvement of 41%, and for SPECT-CT, a further improvement of 60%, all of which are significant. For characterization of knee lesions, bone scan is accurate for 52% of the lesions. For SPECT-CT, there is just a marginal improvement of only 4%, which is not significant. And for SPECT-CT, there is a jump of 40%. And this is attributed to the companion CT that provides significant value in terms of anatomical information. So there is a stepwise improvement from bone scan to SPECT-CT for both localization and characterization of bone lesions. The same trend can be observed in the patient-based analysis. Numbers are different, but the pattern is the same. Knee-based analysis as well, same pattern of incremental value of SPECT-CT. For characterization of arthropathy lesions, bone scan is good, it's able to demonstrate uptick along the articular margins. But for non-arthropathy lesions, bone scan has a low accuracy of 6%. SPECT-CT is also not good, 12%. For SPECT, I mean. For SPECT-CT, there is a jump of more than 80%, and this is again attributed to the companion CT. Bone scan is accurate in more than 90% of the time for the detection of lesions, but SPECT-CT is able to further improve on this. So we know that the bone scan is good for characterizing arthropathy lesions, but SPECT-CT is able to take things one step further. It's able to diagnose lesions causing, contributing, or associated with osteoarthritis. For example, patellar malalignment, bipartite patellar, and osteochondral lesions, and loose bodies. This leads to a more specific diagnosis and allows more specific treatment to be targeted at these lesions rather than just managing osteoarthritis alone. And this can potentially improve prognosis. And of course, the value of CT cannot be overemphasized. This is a 38-year-old man with the left knee pain. Blood pool imaging shows a focal increased rates of uptake in the left knee, and the delayed imaging shows uptake in the left knee as well, increased osteoblastic activity. So this is a rather non-specific appearance. It can be due to trauma, stress, degeneration, non-specific. On CT, there is a left bipartite patella. So is that the cause of knee pain, or is it just an incidental finding? SPECT-CT localizes accurately the osteoblastic activity to the bipartite patella, representing the cause of knee pain. So in this case, combined SPECT and CT imaging improves the specificity and provides a more confident diagnosis as compared to just bone scan or CT alone. So this highlights the incremental value of SPECT CT. This is another case of a 33-year-old woman with bilateral knee pain. Blood pool imaging, normal. Leg imaging shows focal increased tracer uptake in both knees. So again, non-specific appearance. CT shows lateral subluxation of both patellae as well as shallow trochlear grooves bilaterally. And the SPECT CT localizes the activity to the lateral patellofemoral articulation, representing the cause of knee pain. Again, this shows that SPECT CT is able to provide a more specific diagnosis with greater confidence than just bone scan or CT alone. 65-year-old man with bilateral knee pain. So there is focal increased tracer uptake at the medial aspects of both knees. Again, this is a fairly non-specific appearance. Degeneration, could be trauma, could be stress. And this patient has a history of renal transplantation. So with that in mind, we may include the differential of osteonecrosis of the knees. SPECT CT localizes the activity, the sclerotic lesions, representing indeed the cause of knee pain is osteonecrosis. And this case shows focal increased tracer uptake at the superior aspect of the right knee. Fairly non-specific finding as usual. On CT, the bones are normal, no abnormality. So what is the cause of knee pain in this patient? SPECT CT localizes the activity to the attachment of the quadriceps muscle to the patella. So this represents quadriceps tendinosis as a cause of knee pain. Imaging of the post-surgical knee is often challenging because of the distorted anatomy and also the indwelling prostheses. And this will be further covered in the next talk. So in conclusion, when performing a bone scan for knee pain, addition of SPECT CT should be considered because of the incremental value that it adds, as well as the improved diagnostic confidence. MRI is often used as an imaging modality of choice for imaging the knee when there's knee pain. However, MRI is not 100%, it is not perfect, and in cases where MRI is inconclusive, SPECT CT may represent a good problem-solving tool, and therefore MRI and SPECT CT are complementary. And when, in cases where MRI is not feasible or available, SPECT CT represents a good alternative. And of course, for the assessment of post-surgical knee, artifacts or implants may obscure or reduce the sensitivity of MRI, and that's when SPECT CT may be useful. And this scan, this slide put together the bone scan of the 4 patients that we saw earlier on. So you can see that with just bone scan alone, it is not easy to come to a conclusive diagnosis. But with SPECT CT, the diagnosis is clearer and more confident. Thank you.